Thank you. Okay, one more lecture before we have lunch, and we're happy to have Dr. Mende back to talk to us about all the controversy over the past year that has occurred with the new hypertensive guidelines. So I hope you can clarify it for us and not confuse us some more, because the guidelines certainly confused a lot of us about how we treat our antihypertensive patients. Thanks for joining us again.
Well, thank you. Thank you, Dr. Khan, for inviting me again. It's a pleasure to be back, and I think this discussion in many aspects will fit very nicely into the discussion this morning. In particular, there's one thread which you can see is actually insulin resistance. It goes from obesity to diabetes to coronary artery disease to polycystic ovary disease, and also to at least 50% of the hypertensive. So this is the title. These are the disclosures, and none of them will have any bearing whatsoever on it. Just to look at the picture, in the US, about 1/3 of the population is hypertensive. If you look at this, you always think, well, this may be our obesity. The hypertensive rates in Europe, Asia, South America are identical. So it's not our lifestyle, despite the fact that obesity is a significant factor. There is almost a linear relationship. So if you turn age 60, you have a 50% chance of hypertension. Age 75, 75% is easy to remember. Age 90 is 90%. So what happens if you then develop hypertension earlier? So if you're obese, you're inactive, you're insulin resistant, you may be hypertensive, unfortunately, at age 17, as we again see in our youngsters, adolescents who are obese. So we always were taught that the genes are very important in hypertension, and they're somewhere down to the 30, 35%. So age is the number one risk factor by far. If you look at our control rates, they're set to be around 53%, but the CDC, on a survey which is not quite 100% scientific, actually labeled our goal being less than 140/90 at 64%, and that is by a mile the best in the world. If you look at German and British data, they're somewhere around 40, 45%. So we should actually congratulate our healthcare system that in the US, the blood pressure control, the A1C, and the LDL goals are the best in the world. But you won't see this on the front page of a newspaper because good news doesn't sell well. So looking at hypertension, and it's like anything else. If you measure something incorrectly, you have follow-up with faulty approach and therapy. So basically, even when I go to see a physician, I find myself sometimes on the examining table, and it's kind of very difficult for me to say, look, this is the wrong place, let me sit in the chair. So you don't want to be obnoxious, so you sort of give in or up. So basically, excuse me, you have to have your back supported. If you take your pressure on Monday when you go back to work, and it's sitting in a chair, both feet on the floor, and then you sit at an examinal table, legs not supported, you will have about 8 to 10 millimeter higher systolic blood pressure. It's because you're using your muscles. So basically, position can give you this part of the white coat syndrome. So you need to rest a little bit before, so we know that. But basically, one needs to obtain more than one reading. So the first reading is always high and misleading, and I'll get to this in a moment. And we now very strongly feel that the diabetics take their own blood sugars at home, and we let the hypertensive walk around for 3 months before we see them again, or 2 months, and then we'll take another pressure, and this is just not adequate. So people should be taking at least once or twice a week their blood pressure. Don't let them take it 5 times a day. I have engineers who come in and have it meaned out, and then they get the faxes, and so basically it becomes a new disease. It's called blood pressure taking. So, but and the gadgets available are excellent. The best one is Omron. I have no stock in Omron, and at Costco again, I have no stock in Costco. It's about $30 or less. So they're becoming very reliable, and maybe in your office, have them bring it once a year and have them check against your own gadgets, so you know the patient is taking it right and you know the gadget is accurate. So much for that. So a lot of agencies looked at this and said, what is the ideal number? So you can see from there, so you should have a minimum of 2. And if you discard the first one and take 3 readings and average out, you actually will exclude 1/3 of all patients who you thought had hypertension. This is huge. A, they don't have a disease. B, they don't need drug treatment. So this was actually a Kaiser study by Dr. Handler, and these are numbers of 500,000 patients plus. So basically, one needs to take more than one reading. That's the bottom line. Now, those of you who still doubt the quality and excuse me, the aspect of home blood pressure readings is if you look at cardiovascular outcome data. So you look at 5-year data and say, which pressure really matters? Is it the one in the office or the one at home? So the one at home is twice as good a correlative pressure. So you get more accuracy from event standpoint. So that's number one. Number two, there is a condition where patients feel so cuddled by the doctor's office visit that they become normotensive. And they're hypertensive anytime they're outside the office. Not just when they're on the freeways or have quarreling with their spouse or what have you. So basically that's called masked hypertension. So normotensive in the office. You will never make the diagnosis if you don't take your pressure at home. And that's about 8% of the hypertensive population. So it's not a small number. So and here comes my favorite, and we actually did a study very similar, excuse me, at Scripps in La Jolla. We actually looked at patients who skipped office visits, didn't call, or didn't refill drugs, i.e. weren't adhering. So basically, if you start to take your pressure twice a week, you become a participation patient, and you take your drugs, and here's the outcome. You're 4 times more likely to reach blood pressure goal. And that's in a span of less than a year. So having the patient involved, either way you look at it, is a win-win situation. So here is just a general look. Really sorry, I'm flying around too much. Here's a general look. Let me just, thank you. What is at any age, and I'm talking about adults, age 21 and older, what is the average benefit if you reduce your blood pressure, if you're hypertensive, i.e. over 140 over 90? About 10/5 gives you, always the greatest reductions are in stroke deaths and then followed by coronary artery disease. So these are the best data we have, and I think the coronary artery data are not corroborated by all other studies. There are other studies show that that unfortunately with coronary artery disease it may be closer to 30%. Because the lipids and other aspects also play a role. And I thought I'll just give you a study from last week from the JMA, because somebody actually looked very nicely at the type 2 diabetics. And if you are hypertensive as a diabetic over 140 and you lower it by 10 millimeters systolically, here are the numbers. You reduce mortality by 13, CVAs by 27%. So you see, again, stroke is leading. But here was something very interesting, that even if you go from 140 to 130, and I'll give you what data you should really, what goals you should arrive at a diabetic, you still have reduction of retinopathy and of albuminuria. So you still have benefits if you go from 140 to 130. So it doesn't really make any difference what the baseline is. So you need to treat the goal, and this is going to be a big part of the discussion. So if you look at huge trials, I mean, these are 40,000 patients studied. Again, what was said earlier, we don't have too many people studied at age 40 or 45. Most of our studies are people in the 50-plus range, and very few studies include any people at age 80. There's one study which had about 1,700 octogenarians, and I'll show you the data in a moment. So basically, for the age group 50 to 75, we have the data, and the lowest event rate was somewhere in the mid-30s over 85, including a large number of diabetics in the on-target study. So something which has evolved since Dr. Backers reviewed this several years ago. We always learn from life insurance companies that the lower the better. And we still know from LDL somewhat the lower the better. And so the A1Cs sort of fell by the wayside that because of the studies. But I think that we still have to realize that if you have a blood pressure of 120 over 80, because you are young and fit and have the right genes and all of these aspects, versus lowering the blood pressure to 120 over 80 are two completely different worlds. So you don't get the same benefits having your pressure by Mother Nature, quotes unquote, versus achieving it by drugs. So therefore, you cannot use the life insurance data saying that somebody is 90 years old and has a systolic of 110. That's what we all should treat people to. That's what we did for decades, that we thought the lower is the better. And we now know that if you're 50 years or older and you had hypertension for 10, 15 years, that we should not push those people below 130 on the average, and I'll show you who should be pushed. So basically, the only thing you can improve in anybody age 50 plus for the average patient who is hypertensive is stroke rate. So if you had a stroke before, or you had TIAs, or you have known significant coronary artery disease, I like to get the pressure just below 130. Maybe if you pick a number, 125 to 130, and I show you the recommendations. And here's something very interesting because, as you know, we'll see more and more people who develop CKD. The easiest condition, definition is really an EGFR, an estimated glomerular filtration rate of less than 60. So if you look at age 40, you lose 1 ml, excuse me, get 1 ml of kidney function per year, courtesy of age. So if you turn age 90, you lost 50% of kidney function, you donated 1 kidney to Mother Nature. So you see, it's really annoying, I'm sorry. So if you see a person at age 75 and the EGFR comes back reported to you as 58 or 57, don't put down CKD. Just tell the patient you're normal. It's normal for age. Don't send it to the nephrologist. So here's a study of 650-some thousand patients, and they had the EGFRs, let's see, 48, and they were 75 years old. But if you drove their blood pressure down to less than 120, what happens is you doubled their death rates. So it's not just that, I'm telling you, it's not really good. You get lightheaded, you may feel weak, you may feel dizzy. You know, that's one thing. So basically, I can just state absolutely, I don't know of any single study ever done in any hypertensive where anybody could prove that you improve quality of life expectancy, or events to go below 120, because the death rates and the negatives outweigh the positives. So the absolute ceiling, one can really say, is about 120 from multiple studies. So this was the latest here from the Kaiser. So let's start with guidelines. We had nothing after JNC7 for 10 years. Then everybody got so itchy that every agency, from the American Heart Association, the Diabetic Association, who knows, everybody had their own guidelines come out. So they're filling a void, so to speak of. So here is the American Society of Hypertension, and I'm very biased because I'm a member. So I find these are the nicest guidelines. So they're only, a year and a half old. So if you're over 80, you should really get the pressure just below 150. Now, if you had somebody you saw from age 50 to age 80 and they were 135, don't lower their drug. They've been at 135 for 30 years, leave them alone. Don't change your winning team. So, but if you have somebody who is, you see, new, or whose pressure is 155 and they're 80 years old, it is worth it to get the pressure below 150, because the studies have shown that you reduce MIs, a new onset of congestive heart failure, and strokes significantly. So that's actually a good rule. So age 60 to 79, and you have to look if a 79-year-old looks like biologic like 89, or whether a 79-year-old looks biologic like 65. So you really need to look at the patient, not just the years. So you should definitely below 140 or 90. And if you're younger than 50, I think one should make an effort to get below 130 over 80 if it's well tolerated. And if you use the right drugs, you should get there. And the controversy now is with diabetes and chronic kidney disease, i.e. EGFR less than 60, you should definitely be below 140 over 90. I like to be closer to 130, particularly if you have no side effects. So I'll show you some of the other guidelines. There are other agencies who are trending closer to 130, but we don't push people below 130 unless they have 4 grams of proteinuria, or you have special incidences where you really want to push. So I think 125 is the lowest we should get to, and in the diabetics and CKD, 135 is the highest. So if you pendle around the two goalposts of 125 to 135 and stay around 130, I think you'll do a very, very good job, and you'll be happy with the patient's outcome. Now here's JNC 7 and 8. It's the last JNC you will ever see, and many people are celebrating that. Very recent, the NIH pulled the plug, and this is they did as good or as bad a job as the lipid panel people, as you heard earlier today. And I think this is terrible because they made the control go at age 60 up to 150, and if it's like on the freeway, or if it says 70 miles an hour, I go 80, and if it says 60, I go 70. So I think what happens with the pressure will do the same, unfortunately. So I think this was the big criticism. But there's something very nice in this guideline. Look at the initial drug therapy. We used to have this rigid thiazides first, and we had this step care approach, and it doesn't make any sense. So now you look at the patient. You look at African Americans, 85% more salt sensitive, so thiazides make a sense for them as initial drug. And African Americans are more vasoconstricted, so calcium channel blockers, particularly amlodipine, are a wonderful drug. And we know that the diabetics and the CKD patients, one of the drugs should be an ACE inhibitor or ARB. So basically right now, you actually have a choice, and so you can actually use what's best for the patient, what has the least side effect, and what gets the blood pressure to go. So the ADA came up with a very similar goal, so less than 140 of 80, and they said if you're younger, go less than 130 of 80, so it's almost identical to the ASH, nothing to remember. But there's one feature of the ADA which is really impressive, is for the first time ever, they said if you take 1 or 2 or 3 drugs for hypertension, one of them should be given at bedtime. And I'll show you why this become important. As a matter of fact, I've been doing this for 30 years. If somebody's on an ACE inhibitor or an ARB, and the only exception are the thiazides, I would actually give person HS dosing because it makes the most sense. The events are in the morning, the highest blood pressure surge is there. And about 4 days ago, I just added this, the American Society of Endocrinology, they were hedging. They said, what should be the pressure on the diabetics? And they said around 130 over 80. They didn't see it. You see that around there. So they were trying to stay between the guidelines. So basically, I think less than 140 over 80, closer to 130 if you can get there, particularly if you're younger than 80. And here come the HS data. So let's say that this was a wonderful study. So they did an ACE inhibitor and a calcium channel blocker for 5 to 7 years in the morning, and an ACE inhibitor and calcium channel blocker for 5 years in the evening in half of the group. So about 220 patients got them HS, and 220 patients got an AM. And look at the difference. There was a 12% lower cardiovascular events for each 5 millimeter, and that's typically what you get. If you switch a drug from daytime to HS, you have about a 5, 6, 7 millimeter systolic blood pressure reduction through the night if you would do ambulatory blood pressure measurements, which we don't do, but you can take the data from here. So you have, with the same amount of drugs, without raising the dose, a 12 to 14% reduction of events. And that's not, that's pretty impressive. So again, my overall approach is that if you take an ACE or ARB, also people exercise in the morning, they take their ACE and ARB, and then they exercise, and then they're dizzy because the pressure is down from the drug and down from the exercise. So start taking monotherapy, except for thiazide HS, particularly if you have CKD and diabetes, where as the guidelines tell us to do so. And if you're on 2 drugs, take at least 1 HS, and so I think this is going to evolve. Okay, just not to confuse you, but the CKD guidelines are essentially identical to the ASH guidelines and the ADA guidelines, and they say less than 140 over 90. And again, if you have proteinuria, which starts with 30 milligrams per day, which is microalbuminuria in the old scheme of things, try to get close to 130. But again, don't really drop it below 125. So this is the same. And a couple days ago, I just updated this. This was just published online. the American Heart Association and ACC, it's just really confusing everybody. And ASH came out with a combined guideline, and they're fortunately the same like I showed you, less than 150/90. And if you had an MI or had a CVA or had carotid artery disease and you can tolerate it and you're in your 50s, 60s, and 70s, we're tending to get just below 130. So we're actually let it all go up by 10 millimeters and gently notching it back down closer to 130/80, particularly if you had events and particularly also if you can tolerate it. So you get a feeling that the uncomplicated patient should be below 140/90, and if you got any major CKD, MI, other conditions with it, you probably better to be at the 130 range and just below or around 130. So basically, this is what it's going to turn out to be. So we just had this talk about obesity. I'm not going to, can't do any better. I don't have any good pictures or jokes like Dr. Buchanan did. She did a wonderful job. So basically, 75% of the patients with BMIs of 30 or greater have hypertension. And, even if you're 120 pounds and have a pressure of 110/70, and I make you gain 10 kilos, your systolic is going to go from 110 to 120. So even a normotensive individual. So this is from a BMI of 25 to 35 range, because if you get to be 40 and 50, it becomes, you can't calculate this, and you can't measure the pressure with those arms anyway. So basically, 1 kilogram of weight gain is about 1 millimeter systolic blood pressure increase. Same if you lose weight. So this is pretty much it. So the mechanism, just quickly, the renal angiotensin system is elevated. You have always an elevated aldosterone level. You make more leptin, which you heard earlier, and that makes your pulse rate go up. So if you see obese people, they always have a higher resting pulse rate. And if your pulse rate goes up, that actually very often is a sign of sympathetic tone being elevated, and so you have higher incidence of hypertension. So despite our obesity rates in the United States, I found it very interesting that there are no national guidelines. And actually, I wrote an editorial about that a while ago. So basically, what shall one do? So the treatment really isn't any different, but you actually pick a couple drug classes. So the RAS system using ACE and ARB with a diuretic is probably the 1-2 choice for people with obesity and hypertension. And very early, we put down aldactone. So with aldactone, you have to have a kidney function over 30%, and you need to have to watch the potassium. So people are afraid to start aldactone, and you don't have to, because look at your baseline potassium. If your baseline potassium is above 4.5, like 4.7, 4.85, that patient going out aldactone needs another potassium checked in a week or 10 days. If your potassium is 4.1 to 4.5, you have room for the potassium to rise. And by the way, end of this year, we'll have a new powder type thing, which is not a resin, which actually will lower potassiums beautifully. It probably get FDA approved in October. There was an England Journal article. It's called Patty Romer. That's the drug. So we'll have for the hyperkalemic patients a very excellent drug to control their potassium pretty soon. So what about beta blockers? Let me tell you a very important trick for tough to treat hypertensives. Follow their pulse. The only specialty, so to speak, of taking care of hypertension, paying attention to pulse rates, are cardiologists. So if you see somebody sitting in your office with normal thyroid function, without a panic attack, and being super anxious, and their pulse is 80 or higher, and they do have hypertension, you'll have a very difficult time controlling their blood pressure, because a high pulse rate increases your cardiac output. So if you go on a treadmill and you run and your pulse is 140, your systolic is 170, and that's a normal response. So basically, you need to use a beta blocker early on in hypertensives with obesity or no obesity, for both, who have pulse rates of 80 and higher. So if you're obese, and I'll give you atenolol, or I give you metoprolol, you have a 28% chance of making that person diabetic in the first year. And they're also going to gain at least 3, 4, 5, 6, 7 pounds, because you can slow them down. So if you have people with higher BMIs, or a risk of diabetes, one ought to use the vasodilating beta blocker. Well, there's one which is generic. It's Coric or Corvedolol, and it's an alpha and a beta blocker, so no risk of diabetes with Corvedolol. And there's one non-generic, which is Nebivolol, which is a beta blocker and releases nitric oxide, and then is unfortunately not generic for quite some time. So use the two drugs which are vasodilating beta blockers to avoid the development of diabetes in your obesity, hypertension population. So let's talk about another topic. It's easy to control somebody with 150, 155, but if you have patients who are already on 2 drugs or 3 drugs and not controlled, we call them resistant if you're on 3 drugs, including a diuretic, and your blood pressure is still over 140, or you're on 4 drugs and you're finally controlled. So the refractory I'm just going to leave out, so this is just a matter of classification. So what's the key aspect of resistant hypertension? If you look at patients who come to see you and they're on a calcium channel blocker, they're on ACE inhibitor and a beta blocker, you'll never control them. So if you are on any 3 drugs, there's an absolute golden rule in hypertension. One of the 3 has to be a diuretic. Now let's see you see somebody with a blood pressure 146 over 82 or 86, and they're on a 40 milligrams of lisinopril, they're on 10 milligrams of amlodipine, and they're on 25 hydrochlorothiazide. And you need another drug because they're about 6-7 millimeters above goal. Do not give them a 4th drug. Just take away the hydrochlorothiazide and give them 25 milligrams of chlorthalidone. I'll show you the slide, and they will be controlled. So we are missing out by switching to a 4th drug if we could still maintain the pressure by just switching diuretics. So what is the issue with resistant hypertension? 1/3 are not hypertensive if you just do home blood pressure reading or ambulatory blood pressure measurements, which we don't have issue. Half of them who you give 3 drugs take 2, and the 3rd one they skip. And then when you ask them, are you taking your drugs, they say yes, and they're not lying, but they're not really telling you the truth. And then the other aspect is that many patients who are difficult to control would be beautiful to control with all of 25 or 12.5 of aldactone. And if you get some breast tenderness as a male, switch to eplerenone, another aldosterone antagonist, which is now available for use generically speaking. So here's the study showing if you do 8,000 some patients who are uncontrolled in the office, 1/3 are well controlled outside, so they really don't have that. So here are some drug studies from Europe. So patients think, well, you know, he told me to take my pill every day, so how many people really skipped 42% skipped at least 1 day, and then 15% 2 days, and here you can see more consecutive day were 42%. So people keep skipping drugs, taking it daily, and they think they're going to get away with it. And what I think is a wonderful study out of Finland, it actually showed at admissions and deaths from strokes, and it showed that the skippers get punished. So that the rate of death or CVAs from people who skip 1 day, 2 days, and not just skip for a week. These are just short skips. Every other day, take 3 pills a week or so, was 3 times higher. So there is a penalty to be paid for not being compliant, particularly if you look at the number of people, 73,000 patients. And here's just to show you some US data. So what happened in the primary care setting would be very germane to what you do. So if you see patients on 3 drugs, including a diuretic, not controlled, so 22% are controlled if you check the home pressure, 30% or so are not taking their drug, and 40% are on not a diuretic or not on the right diuretic, which is chlorthalidone, and the other ones are taking an ACE and a calcium channel blocker and a beta blocker. And so you need then decide if you need the beta blocker for the pulse, then you take the calcium channel blocker. Amlodipine doesn't slow your pulse. You can take that with a drug like Corvedolol, and then you can add chlorthalidone, or you can use the ACE inhibitor and skip the calcium channel blocker, and you can also use diltiazem as an alternate to the beta blocker, which does not affect your glucose metabolism, and get the pulse down. And while I'm on this, one of the real tricks in medicine in hypertension is you can use both calcium channel blockers. You can have somebody on amlodipine plus diltiazem. It works wonderful in many elderly. So you can have a thiazide, 5 milligrams or so, 10 to amlodipine, 180, 240, and diltiazem works very well, particularly in the elder population. In addition, long-acting nitrates, which we use for angina every other day, or because you're concerned about the tolerance, the on and off phenomenon. There's no off phenomenon in hypertension, so you can give somebody a long-acting nitrate every day, and it will control the pressure, not alone, but as an adjunct to a calcium channel blocker. You get sequential vasodilation, and you can look at it to an ACE. You can use in an 80-year-old an ACE inhibitor, a drug like amlodipine, a low-dose diuretic. If they're still not controlled, consider a long-acting nitrate. So these are just a couple tricks of the trade to treat difficult patients. And again, on this U.S. study, nobody was on clothalidone and nobody was on aldactone. So what do you do with somebody who you see in the office? And you take their pressure at the office a couple times, and you know their home pressure is over 160 over 100. If you start monotherapy, one drug, you kid yourself. Your success rate to reach 140 over 90 is 3%. I mean, who's going to gamble at 3%? It's just not a good odds number. So you start 2 drugs. So we always thought that the diuretics with an ACE was the way to go. So it was a study of some 10,000 patients who were an ACE diuretic versus ACE calcium channel blocker, which was amlodipine, and they kept the pressure within 1 millimeter for 4.5 years, and then the study was stopped because the outcomes were so in favor of the calcium channel blocker ACE. So you don't have to take off your patients of the ACE diuretic, but we now know that the ACE calcium channel blocker combo for many of our difficult to treat patients actually is the superior way to go. And then the third drug would be a thiazide. And as I said, there were 20% fewer results, events, MI, CVAs, in progression of kidney disease, unfortunately, not in the diabetics. So the only ones who really benefited from that combo were all the non-diabetics. In the diabetics, the difference between ACE diuretic and ACE calcium channel blocker was the same. So then to sum up this resistant hypertension issue, so you want to make sure you're really hypertensive, so at least get some home readings. You want to assure compliance in the future. We may get more drug screens easily done and cheaper. You need to use the 3 correct combos, so there should be a RAS blocker, ACE, or A or B, and a calcium channel blocker, and the diuretic should be clothalidone. Well, if you get to goal with a thiazide and you're down to 130, you don't have to use clothalidone, but clothalidone is far superior. I'll show you the comparative numbers. So some of the odds you can evaluate, refer them to cardiologists or hypertensive specialists. And you need to check people for excessive salt intake. I can make you overcome any diuretic action from whatever diuretic you take by just adding more salt to your diet. So excessive salt intake cancels out the effectiveness of any hypertensive diuretic. And the number where things get out of control is 6 grams of salt. So I like to use salt, not sodium, as the way, because you don't eat sodium, you eat salt, sodium chloride. So what's the conversion factor? 2.5. So if you divide the 6 grams by 2.5, that is the sodium content. So these are the converting. So talking about combos, well, what combos not to use is beta blocker and diltiazem. You know, because you get excessive bradycardia. But people still using clonidine with a beta blocker, and don't do that because for reasons I cannot explain, there's no potentiation. So you make people a zombie, so decide what you want, clonidine or beta blocker. But they don't work. There are actually is it one paper by Dr. Giles who he found 3 cases when he added the clonidine that the pressure got higher. It's kind of crazy. So, and dual RAS blockade, unfortunately, I'm sorry to say from a nephrology standpoint, we had so much hope, is a total flop. Okay, so A, it doesn't work very well in hypertension, and what is worse, it causes more side effects, more hyperkalemia, more renal dysfunction. So don't use any dual RAS blockade. However, aldactone and ACE and aldactone and an A or B is excluded because that's not dual RAS blockade in the conventional thing. And here's just quickly to look at the comparison between the two thiazides. And if you are evidence-based, there is no paper ever showing that thiazides have any reduction of any mortality morbidity because all the studies were done with thiazide plus something else. So I'm not bad-mouthing hydrochlorothiazide, but if you're an evidence-based person, all the studies, all had, you name the studies, SHEP, CIS Europe, all of them used either indapamide, which is the losol, or chlorthalidone. So basically, you get 6-7 millimeter more systolic blood pressure reduction if you need it. So go and start your thiazide. But as I said, if you really think about a fourth drug or third drug, use the chlorthalidone first. People use so much NSAID, you have no idea. I mean, these things, I was a consultant for one of the football teams. I can't say the name because it's going to be too complicated. So basically, they had in their locker room a bowl of ibuprofen. And these big linemen, and you should see the hands, they were coming off the field for hurting, and they just grabbed a whole bunch of, I don't know how many, they just took a whole bunch of them and water, and I couldn't believe it. Some of them are hypertensive because they're not just big, they're also obese. So we took that away real quickly because what is the issue? That if you take 3 or 4 days of a NSAID, I make you salt sensitive, even if you're not salt sensitive. And what is worse, your efficacy of every single hypertensive drug goes down by 10 to 15%. So if you, for example, but that's not true for calcium channel blocker. Let me give you an example. 80-year-old osteoarthritis and has to take some NSAIDs every day to have a reasonable lifestyle and to avoid other pain medications such as oxycodone, etc. So that person is hypertensive, so you could get away with one drug, the drug of choice, calcium channel blockers. All of them, amlodipine, diltiazem, do not get attenuated or watered down by NSAIDs. So that's the only drug. Thiazides, beta blocker, ACE inhibitor, A or B, everything gets reduced in efficacy by at least 10-15%. So that's important to know. What is also evolving, because everybody's paying attention to one's memory, is that if you have hypertension, you can develop uncontrolled hypertension. You can develop dementia without having had the CVA or microinfarcts. And we now have new data that the incidence of Alzheimer's is going up in a hypertensive population. So if you look at people who develop Alzheimer's who are normotensive and hypertensive, it is more likely for them to be hypertensive. And also this study was, everybody laughed at because ginkgo turned out to be just useless. But the study looked at ginkgo plus all antihypertensive drugs. And it followed almost 2,000 patients for 6 years. So what's the good news is that all the antihypertensive drugs reduced the risk of Alzheimer by about half. So that's pretty impressive. And this is a Asian population mainly out of Honolulu. So here are the numbers. So again, if you're less than 139 or less than 140 versus 160, your risk for dementia was 4 times greater. I mean, that's huge. So we're paying a lot of attention to all the aspects of lipids, and we should, and to be concerned about Alzheimer's, but I think blood pressure control is very important. And there's something very unusual is that if you have proteinuria per se, over 300 milligrams, and even if you're normotensive, you have a very high risk of cognitive decline, which we don't know the mechanism of. Maybe endothelial dysfunction, but that's just speculation. So basically, even with normal renal function and normal blood pressure and no other risk factors, just having proteinuria may affect your memory. And so what's the answer to that? You try to reduce the proteinuria to the lowest amount you can with the ACE inhibitors, which work there. Something which has a lot of press, and it may not be germane to you, I'm just going to make it practical for you. If you see somebody and they give you their home blood pressure readings, and they're hypertensive, they're over 140 or 190 untreated, but every time you see them, their pressure is all over the place. It's 150 one time, 130 the next time. So they're more than 10 millimeters systolically up and down. Every time you look at them, you never get the same pressure. When you look at outcome data from thousands of patients, that is not good because it actually raises your mortality and events, particular CVAs, about 2.5 to 3 times. And something also which is not very good in that aspect is if you in addition have changes in heart rate. So we think that the variation in their blood pressures may be various sympathetic discharges. So they may be producing more adrenaline or norepinephrine, and depending how much they have, so their pulse rate goes up and their pressure goes up. So clinically, what is important for you in the blood pressure variability? I think the first thing you should ask somebody whose pressure is all over the place is, are you taking your drugs? That's clinically the important aspect of this slide. And the second important aspect is the last paper here, Hussein at the bottom, is just published the last week, actually looked at what drug is the best drug for your patient who's all over the place. It turned out to be not an ACE inhibitor or a beta blocker, which I would have guessed if I had to do a multiple choice. But it turned out to be amlodipine and chlorothalidone, either alone or together, were the best drugs to stop this huge fluctuation business. So you have that, to me, clinically, is what you probably should take home. So if you have a patient all over the place, that's probably the conclusion from that slide. Okay, we don't know most people's blood pressure at 2 a.m. in the morning. So when I start somebody or have a hypertensive, I ask them on the weekend, Saturday and Sunday, to do the poor man's ambulatory blood pressure measurement. I ask them to take their pressure when they get up, 2 hours later, 2 o'clock in the afternoon, 5 o'clock in the afternoon, before they go to bed, and if they go to the John, sit down not just on the John, but sit on somewhere else, so where you're more comfortable, back supported, and get your pressure, okay? With that done, doing this once or twice a year, you get some idea about the nocturnal pressures. Now, normally you and I lower our blood pressure between 10 to 20%. So if you're 140, 10% is at least 14 millimeters. So you lower your systolic. If you're not dipping, that means your pressure is almost the same all day long. And what's the issue of that? The issue is that you have 24 hours of hypertension. So with that, you have more left ventricular hypertrophy, more target organ damage, higher mortality, and we think is endothelial dysfunction. So what do you do? I mean, I can tell you all the things which are nice to document, but basically switching to bedtime of any drug will lower your risk of not dipping. So for me, using HS dosing is not because we found this out from the ADA that this reduces your events of morbidity. We know this from the non-dipping. So the non-dipping was known 20 years ago. So basically using an ACE inhibitor or an ARB, if you use monotherapy or calcium channel blocker, if you use one drug at bedtime, you will reduce your risk of not dipping down to about 15, 20, 25%. So 3 out of 4 patients who don't dip continue to dip if you just use the drug HS. So you're getting 2 benefits from HS dosing. One, you have reduction in mortality and morbidity, which I showed you. About 5 millimeters give you 12, 14% reduction, and you actually ameliorate the non-dipping. So there's a two thing. Now, very quickly, because we talked about it earlier today, this fits in very well. So 50% of all hypertensives are salt sensitive. Anytime you have hypertension with a cause, hypertension with diabetes, hypertension with renal disease, hypertension with obesity, you are salt sensitive 99 out of 100 times. So pure hypertension, usually you're 50-50, but the minute you have a secondary potential cause for it, you usually are salt sensitive. And if you're African American, even if you're skinny, if you do everything right, you're 85% salt sensitive. So we have no good tests for salt sensitivity, and you saw this earlier. So please use that HDL triglyceride ratio. And you saw the magic number, just remember 3. Unfortunately, in hypertension, only has been done in European ancestry. So the studies are ongoing in African Americans and in Asians. But basically, if your HDL triglyceride ratio with hypertension is over 3, you are salt sensitive. You're also insulin resistant. and you have a high cardiovascular risk. So these things all go together. So insulin resistance goes together with salt sensitivity. How come? I'd like to remind you that insulin in the kidney is a sodium retaining hormone. People who inject insulin because they have type 1 diabetes and type 2 diabetics always look edema prone. Their volume expanded. Why? Because their insulin injected or produced by their own pancreas in excessive amounts leads to proximal tubular sodium retention, even if they have a low sodium intake. That's the connection. So now you can lean on your patients who have a high HDL triglyceride ratio to not only lose weight and improve their ratio, because that improves the salt sensitivity, although we don't have that study yet, but you will actually make an impact with their blood pressure control. Again, the study has to be done to prove that lowering the ratio lowers the salt sensitivity. We don't have the data yet. So we always think that the African Americans have the highest blood pressure response. It's the Asians. The Asians are the most sensitive to salt. So you see the number, almost double the response to the Caucasians. The trouble with salt is a lot of it's under your control. So what's the ideal salt intake? Except for CHF, between 3 and 6 grams of salt, and divide by 2.5 for sodium. And those of you who want to do everything right, exercise, eat a lot of fresh fruits, and do everything just perfect to stay healthy as long as possible, don't go on a sodium-restricted diet under 4 grams. There are 2 papers, 7-year follow-ups. You have an increased cardiovascular mortality. Why do you have increased events if you're totally healthy by dramatically lowering your sodium to less than 4 grams? It's because you're stimulating your renin-angiotensin system. You produce a lot of angiotensin too, and you produce more aldosterone, and that's what we're trying to block with the ACE inhibitors. So sometimes if you try to be too aggressive, you should live your life in the middle of the road, so to speak. So basically, the studies show 4 grams of salt divided by 2.5. If you look at sodium, should not be exceeded in norm-intensive people because they think they're going to live higher. And those of you who cannot lay off any salt, just go out on a Mediterranean diet. The higher your potassium intake, it's Mother Nature's antidote to salt is potassium. So if you forget about bananas. 1 inch of banana has 2 milligrams of potassium. So you have to have zoo doses of bananas a day, 10, 15. So any fresh fruit and vegetable, from watermelons to mushrooms, everything is high in potassium. So a high potassium diet can lower your pressure. And look at the DASH diet, which is a Mediterranean diet for hypertensives, 11, 12 millimeter blood pressure reduction, and even reduces a normotensive pressure by 5 millimeters being on a high potassium diet. So basically, potassium is a vasodilator. It's a natriuretic. So if you go on a high potassium diet, you think you took a diuretic. Just do this for 3 days. You'll pee like a racehorse. So it has diuretic actions, just going on a high potassium diet. Okay. So this is the same study, proves it once more time. So I'm going to give you the guidelines at the end one more time. So to me, the best guidelines is 80 older, stay less than 150. If you ever were at 130 all your life, 135, don't change the medications. Between 60 and 79, use your judgment. If you're young, 60 plus year old, you can still go down to 135, 130. If you're younger than 50, we should really make an effort to get below 130 over 80, although we don't have the evidence-based outcome data. Why? Because we don't study people in their 40s. So it's just a lack of events, a lack of data. So, and again, if you had an MI or you had a CVA, the guidelines from last week, you try to get just below 130 over 80 if you have significant other disease in people from age, from 40, 50, 60, 70. It's nice to try to make an effort to get just below 130 and don't go below 125, 120 because you have a J curve, the events go the other way. So, key points. Combination of 3 drugs must include a diuretic. And in my way of thinking, if you need 3 drugs, one of the diuretics should be chlorthalidone, 12.5 to 25. Use 1 drug at bedtime, and I use it for everybody, but it's a must in CKD and diabetes, so you may as well do it for everybody. So if you're not controlled on a thiazide, don't go to another drug, just use chlorthalidone. Try to get some home blood pressure readings. before increasing doses. And if you really have a tough case, consider using aldactone, 12.5 to 25 milligrams, and then you have to watch their renal function to make sure it's over 30 and make sure the K doesn't go above 5.5. Thank you very much.
Thank you. Very nice lecture. Very nice lecture, Dr. Mende. Rare, but I'll come to you, Richard, in a second. Rare, but diastolic hypertension.
Well, the diastolic hypertension is really, it's kind of interesting. When you reach age 50, the systolic keeps rising and the diastolic keeps falling, and it's allegedly loss of elasticity of the large vessels aorta, etc. So typically you would see a 145 over 100 or 105 in an obese 25, 30-year-old. Okay, and I think there the calcium channel blockers like amlodipine are just wonderful. I think in that age group, the dilatory action of the calcium channel blocker would be my first choice, and then you add ACE and diuretic. So diastolic blood pressure, the calcium channel blocker should probably, dihydropyridine calcium channel blocker should be the first choice.
Okay, Richard. Rich?
Yeah. Chris, the guidelines really focus on in-office reading targets. Those of us who move to 24-hour blood pressures and the home reading, what should our target be at home?
I think the targets at home, the definition of hypertension on the ambulatory blood pressure measurement is an average blood pressure in awake blood pressure above 135. So you should have at least a 5 millimeter systolic lower, and at night it's a hypertension. It's above 125. So the trouble is you have two different readings. The awake pressures on the ambulatory and the sleep pressures, and it's 135, 125. So basically, if you say let's mean it out, I think you should be below 130. So it's at least 5 millimeters lower, a minimum of 5 millimeters lower in daytime. What are you using? I mean, there are no official guidelines. I mean, it's just a judgment call. So is it what you're using? You go about 5 millimeters, 8 millimeters lower?
We go for 135 for daytime.
Okay, see the same number. Okay, and then would you try to be at 125 at night, or?
Yeah, well, we like 125 for the 24-hour average.
Okay, so you should actually really were very, very aggressive. So if you just take the daytime and the 125, then you would have to go closer to 120 at night. So okay. So I think there's nothing wrong. I think because there are no strict guidelines. But then if you take care of congestive heart failure, it's really a little bit different. Okay, because it's a totally different ballgame. So yes, it's a very good question. Oh, okay. I tell you what. The risk blood pressure, you got to prove to me that your arm and wrist is the same. And I'm not against the risk pressure, but some of them, it depends how deep your radial artery is and how close to the bone. So if you are deep and halfway under the bone, it's not reliable. But if you show me with the leg compression and measure once and to make it easy for a patient that you get within 5 millimeters of what the alternate method is, so your wrist versus arm cuff is within 5 millimeters, you can skip the arm cuff and just do wrist pressures. But you need to prove that it's within 5 millimeters.
Dr. Shaw.
Well, I think you should just ask the cardiologist, Dr. Wright. But basically, here's the issue. If you have excessive, if you're normotensive, okay, you start out with 130 and you have a excessive hypertensive response, and some people say 175, 180, whatever your response is. These people all at follow-up visits, if you follow them for years. They are all developing hypertension. So this is actually a terrific hypertensive screen. So now comes the second issue is, what is this guy doing when you tell him to exercise, right? So what is this person doing who has 130, 135 systolic every time he's resting or walking in your office? But the minute he exercises or goes on a treadmill, he becomes hypertensive. And I think that we have no guidelines, but I always used on all of them ACE inhibitors. So I think, and then what you can do is to prove to yourself, you can actually put them on an ACE inhibitor, HS, and then do the next treadmill on an ACE inhibitor. Richard, you see this a lot. What do you do with that?
We don't stop a treadmill because of systolic hypertension.
Okay.
We would stop every treadmill if that were the case.
Yes.
Do all old people or all the average blood pressure achieved is about 225.
Okay. Okay. All right. So,
Right. But as Chris said, I push them because if their blood pressure is 270 during exercise, and we see that, they need more antihypertensive therapy.
So the question is basically boiling down to white coat hypertension. Do we treat white coat hypertension or don't we treat white coat hypertension? And there's a lot of argument and debate over that. And we use 24-hour ambulatory blood pressure cuffs to help us. But if somebody keeps becoming hypertensive on the treadmill, that tells you what his activity is outside, and generally we'd say we need to treat those patients.
I think this is a very good point. I think being hypertensive on a treadmill, this is not white coat syndrome. That's exercise-induced hypertension. And I think that, just like Dr. White just said, I think basically if they're on drugs, you need to potentially increase their drug. But if they're not on drugs because they're still 135 or below 140, without exercise and you want them to be active, I think you need to start using a drug, ACE or A or B, HS, and then you'll see on the next, I know from my cardiology colleagues that if they do that, the systolic hypertension is markedly improved or abated when they're on the drug, when they retest them. So you do respond beneficially by treating them.
Okay, Dr.
Well, okay. The rule in nephrology has to be about 70% to 75%. And I think ideally you should measure post-stenotic delta blood pressure drop. Now, you have to put a catheter in. So, but basically it's about 70%. But let me tell you, I've seen people with 85% renal artery stenosis and normotensive. It's not a good correlation.
Well, and I can ask Richard. I mean, just this last week, I stented a patient's infrarenal abdominal aorta. And during the angiogram, the left renal artery had 95% stenosis, the right renal artery about 85% stenosis. And somebody in the lab asked me, aren't you going to intervene? And I said, show me the patient's MAR. He was on one antihypertensive agent and his creatinine was normal. Now, if I intervene on that patient and if I run into a complication and he loses a kidney, I had no justification to intervene. Any comments?
No, I think there are now 3 studies out, and all the 3 studies, the bottom line of all these interventionals, if he would have had a reduction in renal function and maybe a 5 ml each of our loss per year, we call this rapid progression. I would have asked you to stint one of them at a time because you're trying to preserve renal function. But for hypertension, you treat with ACE inhibitor, you treat aggressively to get the pressure below 140 over 90. You use the statins to get ideal LDL, and you start them on an aspirin. So basically, the arm of the NIH and Coral studies, there are 3 studies. The bottom line is that medical treatment was as good or better than stenting. Okay. Now, if you have uncontrolled hypertension because of bilateral stenosis, flash pulmonary edema, I mean, then you have to do it.